Oh, you like that? Did it give you some tips to help?
Yeah, it says change your lifestyle, Bruce.
Well, I did this for myself, right?
Oh, man, it basically says you have an unhealthy work office.
I know I find myself on the couch and go and wonder why I'm hurting. And I'm like,
I feel like you're about to start selling us like some home improvement products. This is
well,
a great segue.
I was asked to do something when the pandemic started for the fall that I think 2020 for the school, and so I was like, well, let me think about this and do some. And so I created that pamphlet because I found a lot of stuff. I'm like, I didn't think about that. Like have something to rest your elbow or your wrists on, that you're not always holding up the neck sort of thing, for example.
Mm-hmm.
Stuff like that, or the keyboard having something that's lower than, so you don't look down or you don't have to type up high. I see that a lot in my practices. The upper body stuff gets really messed up with all that computer work.
Oh yeah.
I see that a lot.
The shoulders rolling forward and then the head getting heavy.
Yeah, it's always this forward thing, it's just like this right. It's this needing to open up in the front a little bit. And I like that visual with the 3 wheels from the side. That really is useful. Did you see that one on the pamphlet?
Yes. But then I'm like, okay, well, that wheel in the middle, it's always that's the biggest temptation, to slouch like that.
That's the key. It gives you the key in the low back because it rounds it back if it goes back, so you get low back pain. But also the head goes forward, so the neck and upper back head. So it's kind of a key ingredient, that wheel thing in the middle.
You should do that for people who are like Uber drivers too, because sitting in a car for a long time is the worst.
Yeah. At least have a good low back support.
Yeah.
At least
Look at Sanju's in his car now.
Yeah, there you go. Hello.
Sanju, you better have a lumbar pillow.
Oh, there he goes.
Yeah, I know my friend, he drives around with a lumbar pillow and it helps a lot.
Yeah, and often what helps to keep that, if we visualize it, what we're talking about right now is sort of the posture where this goes back in the middle and we all cave in, versus sitting up and have this be sort of a level playing field there. And I find a lot of times also that a wedge, a pillow wedge that has a little incline, that also helps to sit on that, like something like this that I'm sitting on right now.
Yes.
Wider in the back than in the front.
Nice.
Then you kind of have to sit a little bit more upright. And so that's what I'm trying to do a little here. But, this is a good place. Hello, everybody. We just started talking about the ergonomic, the home office evaluation. And Bruce and I were just having a little conversation. Anybody else want to chime in on that? How was that exercise for you guys?
It was good. I learned a
That
lot.
was pretty good.
Yeah?
Yeah, definitely. Yeah. I work sitting down all the time in my profession. So, yeah, I've got forward neck posture down. Like, doing this exercise is definitely helpful.
Okay, good. I'm glad. And you were saying something too.
Oh yeah. I realized I have bad posture. I usually sit at the table whenever I do my any work, whenever I do my assignments for classes, and yeah, I learned a lot.
Okay, good. Well, that's the point, trying, to integrate it, make it more palpable, because for me, anatomy is very physical, actually, because it's my own body. And so that's good. I'm glad you get something out of these things. Anybody else have a comment on that? Because if not, I can segue straight into the exercise we're going to do this week. On the same line, we have 2 more exercises. We have one that was that ergonomic. Then we got one that's the posture evaluation. You can see that in my background here, you guys. Anybody
Yes.
feedback?
Yes.
Okay, good, good. And then the last one we'll have is where we do an injury prevention sort of thing. So we're getting a little more physical here. And then that's sort of to integrate the muscle function most. But the posture evaluation is the one we do this weekend. So I'll just start with that because we're getting into the muscles now, and starting with the muscles. And then after that, I want to go to the homework because I know you guys have been working really hard and you've been really absorbing a lot of new terms. So I want to talk about that. But I think, the way we sit is important, obviously, especially since many of us sit so much. So I think it is helpful to have a little input on that, because what we want to do is, the body skeleton is sort of the passive elements of our movement apparatus, and then the active elements is the muscles which attach to the bones, and when they contract, muscles, really all that muscles do is they shorten, so they contract. So either that can mean they move something, like if a muscle, let me go back here, if a muscle's attached, the biceps attached here and then here, and when it contracts and shortens, it moves the elbow and closes it in. So that's one thing. We can get motion of different bones, or also the skin, of course, and the facial muscles. We saw that moves around. But then the other thing we have with what muscles do, if they hold a contraction, they create posture. And so that's where we actually just talked about, was the sitting posture. So it's like the gravity always pulls down, and so gravity likes to go sit like this and just sink in, and we have to sort of use muscles to hold us in that proper posture that is upright. And the proper posture, really, at the end of the day, is the posture that uses the least amount of energy. And what is that? That's a posture that uses the least amount of muscle contraction. And over time, if you sit over time and you head forward like this, these muscles up here, they're always going to contract and have to hold this neck up and hold it up from falling down against gravity. We're talking in this department, I think I have a picture of that, like how heavy the head gets as much as more it goes forward. I think there's a picture on that on the office ergo. And then that uses a much more significant amount of muscle contraction force, and muscle contraction is what uses a huge amount of energy in the body, that ATP. And so when we sit all crooked and have to hold us up against gravity over time, we get more tired than if we're actually sitting in a posture that uses the least amount of energy, which means it's most balanced within the force going down, which is the posture force. So if, like, my spine is balanced, you have a little, it's hard to see here, you have a little lumbar curve here, you have a little curve forward in the mid-back, and then in the neck, you have a curve going this way. If this is all a proper aligned, if your ears are over the shoulder and your shoulders over the hip, and then your knees are over the hip as well when you stand, and your ankle bones are also over the hip, then that's a posture that's quite balanced in the gravity field of going down. And so the energy, because you're sort of upright like that, the energy then is used by the muscle that create the postural holding patterns, those muscles, is not as much as if you were in a posture that's like this and you're going down and you have to, everything has to hold its way up and has to pull up. And then muscles need to use much, much more force doing that. And over time, that's fatiguing them because muscle contraction uses a lot of energy. And energy is ATP. And then that goes, into that discussion where we had the chemistry discussion. Does that make sense, what I'm talking here, blabbing about here?
Yeah, definitely.
Okay, good. So what we then, that's basically here in a purpose. And then what I want to do in this exercise, I want us to look at our posture, and that's a little bit difficult to look at our own posture, but we can do it with our cameras and pictures, and maybe have some friends, or maybe we just have a tripod or somehow put it up and take a picture and figure that out. But I want us to work on that a little bit. So what I want you guys to do in an exercise here is take some label dots or duct tape with a little color thing or something like that, and put it on a few different landmarks. Like, we have a few different views that we have landmarks that we put on. We put it on the back. We put it on the back of the head, the EOP here. So now you're learning these terminologies. See, external occipital protuberance. You know, for years I wrote protuberance, but it's actually protuberance. I kind of, it's like, God, I go too fast over these terms sometimes. I don't even read them right. But anyway, you put one up there in the back of the head, then in the spine on the lower neck where the tip of the spine comes out. That's usually spinous process C6, T1, C7, T1. It depends if it's C7 or T1. It's kind of evenly distributed. We call that the spinal prominence. It's a prominent bone sticking out. And then I want you to put a tip of the shoulder up here, the acromia, which we've learned last week, are these terms, the tip of the shoulder here. And then the tip of the sacrum down in here. So then what you can do, and then from the side, you don't have to put a dot in the ear because you can see the ear, but you have this one already. And then from the side, we also want to use the greater trochanter, which is the bump on the side of the hip, and then the bump on the side of the knee here, the tibial, the fibular head, which is right here. And then if you go for the front, what you do is you dot the glabella. You don't have to necessarily put a dot there because you can sort of see in between the eyes. But then the sternal notch here, that's helpful to put a dot right here in between the clavicle coming together on the breastbone. And then a dot you want on the pubic symphysis is always good in the front. And what you then after that, what you do is you have these dots on you, and then you stand in front of some white background or something light, and you take, you know, not dark, so you can actually see the damn things. And then you take a picture, or have somebody take a picture of you from the front, from the side, and from the back. But what you do before you do that, you close your eyes and you march in place. So if you do it yourself, you can, you know, time it for 10 seconds or something. And then you close your eyes, you march into place, and you come to a neutral stance without opening your eyes. Because what that does when we do a posture analysis, we have, and the eyes have a writing reflex. And as soon as we open the eyes, we adjust our posture that our brain has stored as feeling like this is our neutral posture. The brain has a stored place where it says in the back, in the cerebellum, where it says like, this is the posture. This is like the neutral posture, how the body feels. And then when we open our eyes, the eyes sort of adjust that to the environment, go like, oh, that was a little crooked. And so it balances out. But we don't even notice that, it just does that. So for this exercise, if we keep our eyes closed when we take the pictures, our posture is probably a little bit worse than when we open the eyes. So we can see our aberrant postural patterns a little bit better that way. So that's why we keep the eyes closed. And so I want you to take these pictures. That was me a long time ago, before I had like my COVID stomach. And then after that, you either print them out or you look them in on the phone. And what you do is you analyze them and you transfer what you find on these pictures, the non-balanced parts, you transfer those onto a diagram. Sorry, this is pretty poor quality, but I show you the handout in a minute. You transfer that onto a diagram and you sort of look at yourself. See, my head is forward here a little bit. It's not that far, but it's a little forward. The ear should be back here, should be level up here. And then see how I push my pelvis a little forward because there's this bend. It should be straight, actually, an ideal. So that's kind of a monkey stance a little bit in some ways. I had that from my teenage years. Many of us do a little, I think. And then up here, you can see how this is not quite level to this, not quite parallel to one another. And then the head goes over to the right a little bit. So those are sort of, well, I guess, turning also a little bit. So there's a little rotation in here. So we could go into very, very many details. But what I want you to do is I want you to analyze your posture with going through this picture here. You analyze your picture. And what I've created is a little handout that is here that you can print out or, electronically annotate if you want to as well. See, I also have it down here. So you can electronically annotate that down in here if you want to. So you don't have to print it out if you don't want to. And so once you've done that, I know it sounds like a lot, but it's not that much. Once you've done that, then we go, well, we can also watch this video. That's a 4-minute video that talks about, this is a physical therapist doing posture analysis, if you have more interest in that, or questions of what I'm talking about. And then I want you to answer these questions. Why is posture important? We talked about that a little bit, you know, the gravity, for example, the energy use, stuff like that, what you see in the beginning. And then part 2 of it is I created, well, we just talked about it. The wheel is the thing, right? Most of us have that head forward posture. And so as I looked, what I did, or what I do with my patients in my practice, most of them end up getting some little exercises like this, like a chin. Since the head is forward, we want to bring the head back if you look at corrective exercises. And so most of us don't know really them. So I want us to go through them a little bit and do them a couple times, 3 times a week for a week individually, and then see what effects they give. They're not difficult. It's just like basically the first one I want us to do is you hold the chin and you bring your neck back, so you don't bring your head backwards, like rotate it or flex, extend it back, but you retract it back. You bring the whole head back. Like this is a pretty good picture of that. So that helps. Like I had an episode of really bad neck pain. Like, and when I moved my neck in the night of sleep, it would wake me up. The pain was that sharp for a few weeks when I overworked myself. And this exercise was the one that if I did it religiously for a while, and it's not difficult to do, it helped me not have numb fingers. So it helped the disc herniation to sort of not be effective on the nerve and press on the nerve, where it was like, you know, really a problematic thing to sleep and all of that. So that's a really helpful thing to kind of know for most of us that have a head forward problem. And then once the neck is forward, the second thing we can do, we can stretch the posterior neck elements by holding the chin back, by pulling on the back of the head and bringing that forward to stretch these muscles. The thing with the neck is the muscles in the back here are often very tight, especially the upper back muscles here are tight. And then often the front neck muscles are actually not strong enough. That's part of a problem too. And then another thing is the lateral neck muscles are the side muscles are often tight. And the thing with them is when the side muscles, the scalenes, we're going to get into muscles this week, when the scalenes are cool, they look like the scales on a fish, and that's why they call them the scalenes. But the scalenes have, they're like three bands of muscles coming down on the side of the neck, and between those bands, the nerves come out. And when they're really tight, they squeeze a nerve, and then you get numb fingers. And you think you have carpal tunnel, but the thing is you actually have a neck that's really stiffy because you're sitting or whatever have you, a car accident or something like that. And then on top of that sitting, that really tortured that neck. And so stretching out those side elements is really helpful. I often do, you know, pull, you can do it like you on the side standing or sitting and you pull down, you feel like the arm pulls down, and the other side, you pull the neck over passively a little bit on the neck. And then you feel a stretching here. Or you can also sit on your hand, which is not quite indicated here, but I do that a lot with my patients. You sit on a hand, reach over and pull on the neck over and sort of rotate the neck so it slowly goes towards the armpit, like this kind of way, like slowly goes towards the armpit, and I can stretch these multiple levels of muscles. Don't overdo these things. Just play with it a little bit and spend like, you know, 2-3 minutes, a couple times, 3 times a day on them and see if they do any help. But you know, often we do these things not long enough or not enough, and we don't feel anything. And so I want us to, you know, since all of us don't necessarily have these symptoms, but we're all struggling from these patterns, basically, unless we're, you know, working completely different job or spend our days differently than sitting. I think it's very helpful to go through it a little bit. So then the last one, it is the last one. The fourth one is the Brücker's relief position. And I don't know why they call that. It's just somebody's name. Actually, that's a Swiss guy. So that's probably why they use it. But what you do with that is you basically hold that neck, retract that neck back and open up the arms and bring the palms out, reach the thumbs outward and sort of open up the chest that way. And sort of just take a breath or 2 breath on that. It says, you know, hold 60 seconds. If that feels too long, do not go. Whenever anything that we do physically and it gives you pain or symptoms, or you have concerns or questions, you reach out to me. Don't do it. Be gentle with yourself. You know, don't just give it to me as a reason why you don't want to do it. But, you know, because I do think I try to make these exercises as real life based and as helpful as possible. But if they do create symptomatology or you feel uncomfortable, reach out and talk to me about it. That would be what I'd like. If you could, do not hurt yourself. Anyway, having said this, does this sort of make sense as an exercise?
Yes.
Huh? Yes.
Okay.
Yes, it does.
Good. So what I would like to do now, if it's okay with you guys, and I don't know where you stand on that, I was going to think I'm going to want to go through the homework real quick. Does that sound feasible for you guys? Would you like to do that?
Yes, please.
You know,
Yeah.
the one we had in the past, this week's, let's see, where was that? That was the axial. How did you guys feel about that homework? I'm talking the labeling stuff mostly. I mean, the labeling and coloring is really the key of the learning, the learning the material right now. How are you feeling about these exercises?
It was good. I recently met a medical illustrator at my other job, and yeah, it was really, we got to talk about it. But I like the exercises.
Cool. Yeah, you're sending me these great pictures, right? Oh, I can't hear you now.
Oh, very colorful.
Yeah. I love those pictures. Thank you so much for
Yeah,
doing
thanks.
all the
I
work.
appreciate that.
No, it's awesome work. I really do. I sent you a little note. Well, maybe we can talk about it afterwards at some point. So
fantastic.
I'm really grateful. You guys are some of you guys are so creative in this process. And a lot of, I feel, that's a very important to try. If you have a creativity and you want to make flashcards and just, do it yourself and don't just label it, go for it, do it. I'm totally into all that process, all the creativity. All right, so let's see. We did, where am I here? Sorry about that. We did the axial skeleton. That was the first one that we did this week. Is that correct? Anybody? Hello.
Yeah, that
That's
and I think
correct.
This one, right? Okay. So here, list the bones of the axial skeleton. Those are question number one. So what we have there is basically everything in the midline, right? So it's the skull, it's the collar, it's the sternum, it's the rib cage, it's all the vertebral column, and it is the sacrum. Is that sensible there? Or any questions to that part? Talk to me.
Professor, I would really like it if you could go over where every single term is supposed to be placed.
Okay. Let's go through it then. Let's start with the vertebra. So when we look at the generic vertebra, the first thing we have is the body. That's the body there. And then as we get off from the body, we reach up through pedicles. They're both on these sides here, the pedicles. And then we have this chunk here of bone, and that's where the bone connects. The vertebrae connect to the vertebra above and below through the body, but also through these posterior elements here. And so these are the superior articular facets, and then on the underside will be the inferior articular facets. Those are not labels that you need a label because it gets a little complex. But what I do have you there to label is the lamina, and the lamina is this part here that reaches from these lateral elements back towards the midline and then joined together in what we know as the spinous process. And then laterally on the side here, these two on the side are muscle attachment processes, and those are known as the transverse processes.
Professor, when you say transverse processes, you're saying just the tip of,
This part.
so that entire, okay, thank you.
So then these become these, when you look from the side, it's a little hard to see, but you see it sort of here, it goes up and down the whole spine like this. It becomes like another part of bone on its own self. And those are the inferior and superior articular processes. And then the surface that makes the joint, they call that the facet. So that's where the terminology gets kind of a little involved. And then the piece that sticks out from those bulky parts on the side, that is the transverse process. And then in the cervical spine, since we have distinguishing features, we also have the transverse foramina right here, and we have the bifid spinous process as well. Those are some distinguishing features that you can see there. Then this is the atlas. This is the axis. This here is the dens on the atlas, the thing sticking up. And that's why often we look at the C1, the atlas, and C2 axis together, because they sort of form its own unit with that middle piece here sticking up, and that's then held really by strong ligaments to the vertebra above in a functioning, you know, in a living body, because the spinal cord goes up and down right in the back. And we have to be very careful that this bone does not move back into the spinal cord. So that ligament is very, very crucial. And so then this complex, this upper cervical complex, what it does really help us with the rotation of our head. So most of the rotation of our head, the saying yes, the no saying, the side turning comes from these two joints right here, about 50%. Mm-hmm.
Does the C1 act as a shim, like under the skull between the C2?
Yeah, you know, that's a very, very interesting thing, because a little bit, because often what you see is they do move laterally, like when I work clinically on patients, and then it does tilt the head a little bit too. It stiffens the joint up. So yeah, it's definitely, it can do that a little bit. The other thing that I want to, does that help?
Oh yeah, I was going to say it doesn't have a disc. Does it?
No,
Like
this
that.
doesn't have a disc. The discs start below C2 downward.
Thank you.
But what's important here too is this is clinically speaking, some pathologies weaken this ligament, and then that becomes really problematic. Like Down syndrome has that, for example. That sort of, when it freaks me out when they play soccer and you do headers. Or a very heavy rheumatoid arthritis can have that ligament weakness. That's one reason why if we have that pathology, we actually look at the space between these things and see if that's too wide or is okay. So that's clinically sort of where that comes important. But then when we go down here, we have the thoracic vertebra, and the big thing there is that they are very long. The way that I have the picture, let me find. Where are my pictures? Where are my pictures? Thoracic vertebra. No, this is the joint. What am I doing here? Parts vertebra, unique features. Here we go. So there we have that thoracic vertebra. The thing that's really there is the spinous process is really long and slender and goes down. And so you actually feel the tip. Sometimes they are sore or so, and you're actually touching a vertebra that's further above than you think. And then the other thing is the rib cage comes in here. So that's sort of the thoracic spine is where the ribs come in. And you have different areas on the transverse process, but then also on the body, you have a couple of indentations where the ribs attached to. And so that's a distinguishing feature for that. And then when we look at the lumbar spine as a thing, distinguishing features there, they're really thick vertebrae, and their spinous process becomes long and sort of spade-like a little bit. They need to carry a lot more weight. Their transverses become smaller in terms of them sticking out there. But the big one is really the big vertebra and the spade-like spinous. And you want to know these distinguishing features really at the end of the day, that you can just decide, is it, what kind of vertebra is it? From which section does it come? And so we discuss them because of that. So if I were to place the vertebra on a table and you tell me which section it come from, you could tell me that. So I'm not asking specifically in the test, I'm not asking what are the different features. In this test, all you got to do at the end of the day is you got to determine what, give me terms from that term list. And did you see, by the way, you already moved practically through 2.5 columns of terms. We only got a little bit left. I just want to point that out that, I know it's been really tough getting through all these terms early on, but what we do now is we start integrating them more and more, and hopefully then, they get easier and easier. So you've already done the lion's share of terms for this next exam. So just know that, and when you get overwhelmed, help yourself getting less overwhelmed by maybe remembering that. All right. Anyway, then this is the sacrum, and on the sacrum, what we have is we got the base, which is the top. It's like an inverted triangle, and so then the apex is the bottom part where the triangle comes sort of together, or they comes together. And then the other couple terms we learn here is the transverse lines, which are these lines here on the front part of the sacrum. This is the front side, and they are remnants of the intervertebral discs in the spines. That the sacrum is sort of fused intervertebral discs, fused vertebra together. And then the other piece, when you look from the back, we have sort of the remnants of the spinous processes, and that's called the median sacral crest there. And then we go below, and below is the sternum. The other thing I need to say in the homework, make sure you use all the terms on the list, because those are the terms I'm going to question you. So don't worry about using other terms that are not on the list, because there's plenty of bones to study and plenty of little bumps on the bones. And believe me, I don't know them all. I would not want to know them all. It's too complicated. But I want to know most, and then I get into detail when I need to know it, and then I can look that up. That's why you have an atlas or look it up on Google or so. So focus, but do use the terms on the list, because I don't give you points sometimes if there are too many missing, then I don't give you points for that part. And I do not give you partial points. I just give you 0 or 4 or 5, depending on what it says on the rubric. Make sure you read the rubrics. And then all you do is you finish it up and go through it again, upload it again, and I see it in the background. And if I don't see it, just shoot me a prompt or a text or something and say, hey, I uploaded it again. Can you go through it again? And then you get the full point. So even if the due date is passed, I don't care about that. The completion of the work is more important. And I try to be so generous, but I also want to make sure you don't miss terms. And then on the test, it's like, well, I didn't know about that. And so go through the whole list. And the best thing to do, by the way, is you just print. If you go to the test review, let me go to the test review real quick since we're here. Where is my test review? Test review, you go through under the test module, you go through the anatomy term list and you print that term, you click on here, and then you get to this list right in here. And see, we've already done all the terms up to here. So all we got to do now are these terms, and that's it. So be proud of yourself. But I will print this out, and I would know this list fairly well, because that's what the test is based on. And then the other thing on this tab here is the picture more. The second tab is good because you got videos that go through all of that, so you can just kind of passively sit there and watch them and marinate the information that way. But then also the pictures of the models, I think, is good, and that's printed out. When you click here, you get to this term here, and that's all the pretty much, not fully, but pretty much all the bones. Well, it's all the bones, but they're not necessarily showing all the terms on the bones, because I had to do this in a hurry when COVID started. But go through that too, and maybe download that electronically or open it again, and then make sure you can label these terms on these bones, because that's the models I use for the test. Anyway, back to vertebrae. I'm shattering around here. I gotta get moving. So we have the sternum, we have the manubrium on top, then we have the body of the sternum, and then we have the xiphoid process on the bottom. I like that word. And then on the ribs, I want you to give me the true ribs, which are all the ones that directly go into the sternum up to 1 through 7, then the false ribs, the ones that feed into the last cartilage that then go into the sternum, and then the free floaters, the last 2 ribs, or the floating ribs, the 11 and 12, they do not have any attachment to the cartilage. That's one reason why when you massage somebody, you don't want to make sure you don't scoop them up on the rib. That could be hurting. I had a patient who had such bad scoliosis, which is a side bending of the spine, that her rib on the bottom was caught on the hip, and it hurt when she walked. And when we straightened out the hip, it would be better. That's why we figured out that was the end, that was what it was at the end of the day. So that was pretty interesting, or, you know, problematic. Here's the head of the rib, then we got the neck of the rib, and then the tubercle of the rib. There we go. So that's this part. Now let's go to the next part here, briefly, the homework. Let's go. Where's the picture? There's the picture. Oh, I also wanted to tell you something. I put up videos. Let me just go there real quick. I have a whole set of mostly two semesters of videos that solve the questions on the quizzes, or they're not called quizzes anymore, but the lecture questions. And I put them up here under the questions. So if you like go through the questions, and have questions about going through the questions, I've answered the questions in a class, and then sometimes it becomes a Zoom because it was 2020. And I go through it. So these are not mandatory. And I wrote down how long they are, because on the phone, or so you can see the length here. But they're not mandatory at all, but I wanted to integrate them where the relevance of the material is. So in case you would like to use them as solving the quizzes or the questions, please, watch them and give me feedback on them, or if I didn't put them up so far because it felt like it might be too overwhelming. So tell me that too. It feels like too overwhelming. So, but you don't have to watch them. They're just there for you guys. Anyway, so next we get the scapula. Scapula is a back view and a front view. The back view you can see because you see this line here, and that's the spine of the scapula. Above the spine, we have a little indentation. Indentation is often called a fossa. So that's a supraspinous fossa, and below here is the infraspinous fossa. And then when you follow the spine all the way to the tip of the shoulder, this is the tip of the shoulder. See here, this thing, this is further down on the list, the glenoid cavity, and the humerus right in here fits right into this part here. And so then this becomes the tip of the shoulder. So if you follow your shoulder out to the tip and you have a little drop down, that's this part, and that's known as the acromion. And then when we the acromion, and then when we turn the scapula around, and then see the front, on the front, this here is a little hook, and this is known as the coracoid process. So let me show you real quick. So the shoulder, you can go on the shoulder. Here's the spine of the scapula. I mean, you see this, and you feel this ridge, and you go to the tip. And then on the tip here, you see a little up and down drop, and that's the acromion. And then you can turn around and go a little down, actually, and you feel the humerus right in here. And that's the head of the humerus, which we'll go to. But then you go a little medial, and you got a little bump. And if you push hard, it hurts in that bump. And that's the coracoid process. So that's sticking forward from the shoulder blade here. And then the muscles attach here, and the muscles go down into the rib cage to hold the shoulder blade forward a little bit, but also into the arm to help the arm movement a little bit. The coracobrachialis would that be. And so this here in a lecture, or in class at least, I always call it that coracoid. It's like the raven on the wedge sitting there. And so that's how I remember that. And so that's the coracoid process. And then last on the scapula, but not least, of course, because there's a lot of muscle attached and really hard to reach when you work them, is the subscapular fossa. And this is right, the front part that goes, this part goes towards the rib cage. And so towards the rib cage is where muscles are attached in here. And so we call that the subscapular fossa, to then have muscles that actually attach on this ridge, and they go inward towards the rib cage. forward and they hold the scapula in towards the rib cage. Those are known as the serratus because they look like a serrated knife on the ribs. If you watch boxing, they're like on the side of the ribs, they're sticking up. And you can see that. And then we have muscles attached on this ridge that go towards the spine that hold it scapula on the spine more, and so forth. We have a few of them. But the reason also why you want to know that term subscapular fossa, infraspinous fossa and supraspinous fossa, because we are going to have muscles that known as the supraspinatus, infraspinatus, and subscapularis. So those muscles will be, those are the muscles that hold the arm into the scapula, and those muscles are named, most of them, by where they are located. So that's one reason why I make you study those. All right, never mind. Then we get to the humerus. The humerus is the head of the humerus is here, right here, the round stuff. And then the neck, we have two necks. We have one neck, you know, below a head, you got a neck. And so the round thing here, where that roundy, no, that line goes around the whole thing where the round head stops. That's the neck. That's the anatomical neck. And then what happens here, we have a few bumps, two bumps, a lesser tubercle and the greater tubercle. And these are muscle attachments. We'll talk about that later. And then down here, we have a narrowing of that humerus, and that is known as the surgical neck. And the reason why they call that the surgical neck is because that's where the humerus breaks most. So the anatomical neck is more the real neck, if you are technically correct, but the surgical neck is where the humerus breaks, if it breaks more frequently. And then here on the, when we go down the shaft, on the side of the shaft, we have the bump, and that's the deltoid tuberosity. And then as we go down below, we have these two bumps here, and then these bumps over here. So these two bumps, I don't name, they have names, but this is too many names. So we'll leave those names up. They'll make the joint with then these bones here, which are the ulna and the radius. The ulna and the radius, when we talk about these bones. The ulna wraps around in the back here, which is kind of interesting because actually your elbow proper, if you touch your elbow, you lean on your elbow, this is what you're leaning. So you're actually, this bone here, the ulna wraps around here and wraps into this indentation. That indentation, this is the back of the distal humerus. That's known as the olecranon fossa. So we know that terminology we study, but these two bumps we don't. The capitulum and trochlear gets a little too much. But what we do study is the bumps above them. And these two bumps are known as the epicondyle. The medial epicondyle, which is where the medial side is, where the head of the humerus is, and the lateral epicondyle on the opposite side. We do study those because they become important muscle attachments. Anyway, and then when we go further distally, we get to the humerus, the ulna and the radius. We already said this is the ulna, this is the radius. On the radius, we have a round thing on top. That's known as the head. We got a bump here. That's the radial tuberosity. And then we got a narrower portion, and that's actually the narrower portion here. And that's the neck. So we got head, neck, tubercle, or tuberosity. Tubercle and tuberosity, it depends on the anatomy books that you read or look at. Sometimes they interchange them. One of the things that drove me crazy learning anatomy is like you got different terms and you don't know when they are meaning the same thing or when they're not meaning the same thing. And so I try to differentiate those as much as I can or give you AKAs wherever I can, also known as that. And then as we go distal on the radius, we get to the bump in here, the distal part, which then here becomes the wrist. So if you look at the wrist, you turn it upside down, but you see here comes the radius and then here comes the ulna. So the radius is actually thicker on the bottom, here thicker on the bottom and thinner on the top. The ulna is thicker on top and thinner on the bottom. So don't be fooled by that. But then let me look at this from this angle, because here that's then that distal radius. And you see that bump here, that's the styloid process. And the one thing that I like on this picture, even though it's very small, the radius goes to the thumb side. So always know that radius goes to the thumb. Because when you have to orient muscle afterwards, it's important. It's easier to understand it that way. So when you want to draw here, this would be where the thumb will be. And then when we get to the ulna, we have the olecranon process, which is this big bumpy part, that tip of the elbow, basically, that wraps around here the humerus. Is the olecranon process. And then below, we also have one of those spiny things, those styloid things. Styloid means pen, by the way. It's this one over here sticking out, and that's the ulnar styloid process. Good. And then from the wrist perspective, we have carpals, metacarpals, and phalanges. You do not need to know 1, 2, 3, 4, 5, or whatever these little things mean. It's too complicated. Or it's not too complicated, it's just too much at once. I don't want to minimize what we do. We do a lot of integration work. Once you got this stuff down with the level that I teach you, I feel like you have a really, really solid foundation in anatomy that you can build on. So don't feel like it's not, it's minimal. It's a lot of stuff we're studying. But I don't need to have you go through these details unless you really, really want to. Okay, then from there we get to the pelvis, and the pelvis. And if you have a question, just butt into me. I'm just chattering away. And is this helpful, by the way?
Yes.
Okay, good. So then we got the pelvis, we got the crest. And if some others don't feel it's helpful, just shout out and we can do it privately. But I'll keep going until I get a no. We have the iliac crest here. When you look at the pelvis, you have 3 bones actually that are making up the pelvis, and they kind of split in here. So the top portion is the ilium, then the portion that comes forward to the pubic bone is in the front is the pubis, and then the piece where we sit on the sit bone part, the back, is known as the ischium or ischium, depending on who you ask. And so when we look at the ilium, we have a few things I want to point out. One is that crest. So that's the line on top. That's the iliac crest. And then in the back, we have a big bump. That's the posterior superior iliac spine, sorry. That's a big bump. You can feel it on your own spine. If you reach back from the crest and you feel a bump where the sacrum comes together, that's this PSIS, we also call that. If you go and follow the crest to the front, you get to a sharp bump in the front. If you hit that, it probably hurts, actually. It's pretty sharp bone, right skin right over it, not much muscle. Or no muscle. And that's the ASIS, the anterior superior iliac spine. And then let's go back to the back here, because when we reach further back, we get this notch in here, this big thing in here. And that's known as the greater sciatic notch. And then this is harder to see. Yeah, no, you can see it here. Here's the indentation that then the head of the femur goes in, and that's known as the acetabulum. And then the iliac fossa is the part on here, on the inside, the fossa, iliac fossa. The pubic symphysis is the is the joint. The symphysis is actually the whole joint. That's this joint here. And then the ischial tuberosity is the sit bone. There's a lot of muscle attachments there, that's for sure. So that's the pelvis, I think. There's not even that many. I thought it was more. Well, good for you guys. All right, then we get to the femur. We got the head is the round thing. Then guess what's this called? The neck. And then we got bumps, like on the humerus. We got 2 bumps. We got a big bump and a small bump. Now here they're not called tubercles. Here they're called trochanters. But trochanter, tubercle, again, bumps. Trochanter is the biggest bump we've got. If you judge the outside of your hip, that's big bump there, that's a big bump. That's this big bump. And that's known as the greater trochanter. The lesser trochanter is really hard to feel. That's like on the inner thigh. So you have to go really, really high up on the inner thigh, and then you feel a bump there. When you look at the back of the femur, the thigh bone, you got a little ridge here, and you got a lot of muscles attached on that ridge. You got most of the adductors, which are the muscle on the inside that pull the leg medially. But you also have a lot of the quads, which are the front muscles, the big ones in the front of the thigh that straighten out your knee when you kick it. And that they're also attached back here. They actually reach around to the front. So that's pretty interesting. So that one we need to know. That's the linea aspera. Linea aspera. And then when we go distally on the femur, we get to these 2 honking bones. These are 2 condyles. Remember on the humerus, you had epicondyles. The epi means above, and generally a big thing that makes a joint is known as a condyle. You have it in the skull also, occipital condyles. And in the knee, you do say that condyle. In the humerus, I don't make you study it because they make them have specific names. They're still condyles, but they don't name them condyles anymore. They name them capitulum and trochleum, which we don't study, but just so you get the picture. So we have one on the inside. The head of the femur is on the medial side. So that's the medial condyle. And we got the lateral condyle. And then we got a patellar surface in the front. That's where the kneecap goes, the patella. And the kneecap is a sesamoid bone. That's really cool. It helps smooth out the contraction, the force transfer of a muscle contraction onto the knee. I think I have it in a video somewhere. And then we got the tibia and the fibula. The tibia is really where the weight goes down from the knee downward to the ankle. And the fibula is sort of a stabilizer on the outside, stabilizing bone. Very not insignificant at all. It's very, very, especially involved in pain syndromes. That's where it actually really is also significant. But on the bumps here that we need to know, we have on the tibia, we have condyles. They are these things where the femoral condyles can sit on. We go on the outside, one a lateral, one on the inside, a medial. The fibula is on the outside, so you know that's lateral. And then on the front of the knee, we got a bump, which is kind of a renal on. That's the tibial tuberosity, big muscle attachment for all the thigh muscles in the front. The quads go all into here. And then as we go distally, we got a medial malleolus. And on the fibula, we have a lateral malleolus. Sorry about this thing here, this picture. We have a lateral malleolus. And then in terms of the ankle, the thing I wanted to know, because we studied the hand and sort of what you have a similar, you have instead of carpals, you have tarsals right here, and then you have metatarsals, and then you have phalanges. And so we don't need to worry about all that, but I want you to know the talus. I mean, we do worry about all that. We just don't name it right now. We have the talus, where all the weight comes down and through the tibia. And then we have the calcaneus, which is the heel bone in the back. And so I want you to know those two on that. Whew, good. All right. I guess that went a little different than I thought. How did you feel about that?
Better.
Yeah, I appreciate it. Very informational. Thank you.
Good. No, that's perfect. So let me briefly go through the week. I mean, I think we're gonna leave out the quiz this week and maybe do one next week. Do you feel all right about that?
That sounds
Yeah.
good.
Yeah.
Yeah.
Gives us a little more integration time. Well, all right, then this week, what we're gonna do, we already talked in length about, this is week 6, right? Yeah. Not week 5, week 6 now. We're gonna go through muscle. We're gonna start with muscle function. And this is a physiologic, more physio concept. So this is sort of where we kind of pick the tissue chapter up a little bit in terms of going through the micro stuff on, like, what does muscle do? Muscle function, is it shortens? What does that it create? Posture, etc. Give me some characteristics. So we talk about that. What is muscles active stuff? What is passive stuff? A little terminology. And then we have different types of muscle. We have skeletal, cardiac, and smooth. So we talk about those types briefly. And then muscles and nerves also will have a lot of coverings. So I want to briefly, so it's just the micro stuff of how muscle looks before we just start naming the big ones, and how it's set up, and then how its function works. And so go through that a little bit. I want you to focus mostly on that part, that chapter in terms of understanding, and we can then discuss it next week if you'd like, the details or the things that are hard to understand. And then do the questions. It's not part of the main test in terms of, you need to memorize all of that. The memorization in here, and again, it's not even fully memorization because it's an open book test, but the organization of your test material is the names, is the term lists that we have. This chapter then, goes into how does the nerve talk to the muscle? What energy does the muscle use? Different muscle fiber types. Different contraction types. So you learn a bunch about that stuff, which you probably learned from Jim, some of it. And then how in terminology, origin, insertion, where the muscles attach. And then when we talks about muscle shape, also we have different shapes, how the muscles look. So he talks a little bit about that. And then things that help the muscle, like we talked about the kneecap already, how in the video, he talks about, I think in some videos, he talks about how it distributes the weight. And so go through this chapter, again, focus on understanding it and on doing the questions, and then we can kind of put that to rest. This is not part of the testing material. It's not that it's not important, it's just a lot of stuff. And so I want, don't make it not important, but don't freak out if you don't fully understand it. And then we can talk about it. Bring this chapter, make sure bring a lot of questions next Monday. I think that would be the best approach there. And I'm happy to, and by the way, this is the other thing I will want to mention. Again, I am happy to do study group. We can do study group, for example, after class, if some people have time, we can do, and we can record it and we can then upload it for people who can't. So we can do question answer sessions that way. Is kind of what it is. Or we can also do maybe one even Sunday, depending, or Sunday morning, depending. So give me feedback on those, maybe on Pronto, if you do like to do some of that stuff. Anyway, as a second part then, or as the second big part of this this muscle movement apparatus, now we're really starting to talk about muscles. And when we start talking about muscles, I have some tips here. I have a muscle picture flashcard, which when you press on there, is basically a document that you can print out that has all the muscles that we worry about on it. And you can cut them out and label them and put them on flashcards, draw, color them, do whatever you want with them. But that's a tool that is back there for that. Then the other thing is I have cadaver videos, but I show you how I embedded those in the muscles themselves, in the bullet points. But also I have my favorite muscle picture, which is an electronic picture that I created for my own self, that you can zoom in and you have every muscle that you ever want to know about pretty much. And you have it labeled and visualize that it shows you the attachment on the bone and then a line, and it really gives you a clear understanding where that muscle attaches. And then if you go in your stuff, like let's say you do PT or physical trainer or anything biomechanics, this helps you really a lot, or helps me really a lot, to understand the motion patterns that somebody does. If let's say they come in and say like, it hurts me when I do this motion, and I can really start pinpointing what the attachments might be. Where does it hurt? I can start pushing on those and say like, does that hurt or this hurt? You can be very exact. So again, that's nothing. You're starting the material, but I also want to give you all the tools that I have created for even myself over the years of practicing as a body worker and chiropractor, and give you, just in case you are interested in that detail, or you could use it later professionally. So again, no need to do it, but if you want or have an inkling for it, then go for it. So here this week, we start talking about the head and neck moving muscles, the back muscles, breathing muscles, and the abdominal muscles. So those basically are the trunk things. When I talk about muscles, I have the muscle name. I indicate the attachments. Origin is an attachment and insertion is an attachment. Generally speaking, origin is the attachment where a muscle, I think of it, originates from, like its starting point, like an anchor. Origin is the anchor, and insertion is what moves. Some muscles can have reversibles, origin, insertion, but most of the time, one part of the muscle anchors it, like here, this is the anchor of the trapezius, and then it reaches out into the shoulder blade and the clavicle, and it can start doing movements in that direction with those things. It hardly moves the spine over, it mostly moves the extremity. And so that's where the origin is sort of the center part, and then the insertion is the part that moves around. And I indicated here where they are. And then I say an action. Then an action is, what does it do? When you move, when you contract that muscle, what does it do? That's the action. All right. And then what I did on these, every muscle, or almost every muscle, I should say, has, and look, this is a minute-long video clip behind.
The large muscle which overlies these
about
three is the trapezius. It's a beautiful but complicated muscle.
So it's this guy, this British guy, who's saying, it sounds a little boring, but it's only a minute and it's very precise, and you can see it in a real embalm cadaver, unless that gives you trouble. Of course, you don't have to do that, but to look at that. But this is extremely helpful for studying mussels and understanding them at a really very detailed detail. And I think even at our early stages, the more of studying this topic for most of us, the more understandable visual type of detail that we can create, the better we understand it from the start. So yeah, we go through all those muscles, your back muscles and breathing muscles and abdominal muscles. And then after that, of course, you will have some integrating questions in here. And then after that, you'll have some labeling. We do not have anything labeling on the physiology part, but on the trunk muscles, we talked already about the ergonomic evaluation. And then we finish up. I mean, we already did that, so we discussed that this week, and then we do the posture evaluation to finish up the week and sort of get an understanding of these trunk muscles a little bit more. All right, that's it. How are you doing? Understanding that?
Yes, thank you.
Sorry, it took a little time.
Professor,
Yes.
I'm a bit confused on the difference between insertion and action.
An insertion is an attachment to a bone. So
Okay,
you have insertion and origin go together. So on a muscle like the biceps here, this is the origin where it attaches on a bone. And then down here is the insertion where it attaches on the other bone. So muscle is a long thing that has at least, sometimes has more, but at least 2 attachments. And then the action is when that muscle contracts, what moves? How does the body move? Like here, it flexes the elbow. That's the action.
okay, that makes more sense. Thank you.
Okay, and then later on, when you go into, I don't know, bio 2 or so, you also have what's called innervation, and that's which nerve talks to the muscle to tell it to move. But we don't worry about that. That gets way too complicated. I get always confused with that, so I don't worry about that.
Okay, thank you.
Mhm. Anybody else a question? Oh, no.
No, I understand.
Okay, cool. Well, if everything is clear, again, sorry, it went a little over, but give me feedback if this is helpful doing these homework solving. I can totally do that every week. That's not a problem. But we can also do it just individually if you have additional questions, or if the majority doesn't like to do that if it's too much time. All right.
Professor, where was that? Those diagrams of the neck muscles. Under what tab was that? The ones you just showed before the
Yeah, it
cadaver.
should have been under the movement of the moving. Oh, here on the trunk muscles.
Okay, trunk muscles.
Trunk muscles, and then once we get into trunk muscles, we get into into
That's it. That's it. Okay.
Cool. Good. All right. Anything else?
Thank you.
You're welcome.
Professor, when is the second exam?
I don't know. Hold on. I forget those things. I'm trying to figure out when we're going to do all the dissection. We're going to do the dissections towards the end of the semester, by the way, because, and I'll talk to you guys more about that, because they want us to do it within 2 weeks. I want us to talk about things and then do it afterwards. Otherwise, it's not making too much sense. So let's see the exam number 2.
Your syllabus says March 14th through the 20th.
Does it? No, 18, 22nd. Week 8, and then it's next to it. But I'm going to probably extend it, not have it to Tuesday, probably have the whole week. So it's going to be, so this week, wait, let me show you. Hold on. You're not even seeing what I'm seeing. Hold on. Sorry about that. I thought I shared. Here we go. So we have, this week we go into muscle. So that's the axial muscles. And then next week we do only the upper extremities. So we'll spend 1 week on the uppers. And then we spend the next week on the lowers. And then I start opening the exam on that Friday. And I will keep it open, I'm sure, till the following Friday to give people enough time. That makes sense?
Sounds good. Thank you.
And
Yes,
so we
thank you.
should do, you're welcome. We should do some quizzing stuff here. So I really prepare you for these exams, okay? So next week and then the week 7 and week 8, we're gonna really do some testy stuff. So you guys are ready for the test, okay?
Okay.
Do not, that doesn't mean you don't show up, okay? I'm not gonna hold you accountable if you don't know it, but it's all here to train everybody a little bit. All right, good. Anything else? Without that, we can call it quits and have a wonderful week. If you want to chat after, just stay on. I'll be here for a couple minutes. But you guys are doing great work. I'm really happy to have this class, and I'm grateful for all of you.
All right, thank you, Professor. Thank you.
Thank you, Professor. Have a good day.
You too.
Thank you.
Bye-bye.
Professor,
Yes, sir.
very informational.
Thank you. I'm glad. Let me know what else I could do, and let me know if it becomes too repetitive and I can change it a little bit. Okay.
No, it's good. It's
All
good.
right, cool.
Bye-bye.
Bye. Thank you. Thank you.
Hi, Professor. The